All right, I think we're all set now, right? All right, good morning, everyone. Today is all about breast, okay? We're actually on to module 11 now. They're actually going to go quicker after this. I think almost every week will be a new module. So I know the first 2 weeks were respiratory, the next 2 weeks were GI, thereabouts, and then now we're heading on to the breast, and really module 12 comes up within another week. So now a lot of this is going to be review, as you're already familiar with all of the basic cytologic processes and histologic features. But there's some unique things about the breast that hopefully you will, our goal is to help you learn about that today. The plan for today is I'm going to lecture this morning on the pathology, the histology, the physiology, the pathology of the breast, the histopathology of the breast. And then we're going to take a break today from 11 to 12 for lunch. And then we're going to come back at 12 and do the cytology lecture. And then right after that, we're going to look at cases at the microscope that I'm actually going to be reviewing with you. So that's the plan today. And I actually invited the fellows and the resident that we have rotating on cytology this month over to hear the cytology portion and to look at the glass slides too. We should have room for all of them. All right, so the breast, embryologically, the breast basically is a sweat gland. Okay, it actually develops like one. And it's also known as a sudoriferous gland. Development begins during the 6th week of embryonic life. The ectoderm, most of it is ectodermal. And what happens is the ectoderm becomes thickened along milk lines, which actually run in all mammals from the axilla to the groin. Now, obviously, in humans, we normally have, one set of nipples that form from this milk line. But you know that there are conditions where people will actually have what we call supernumerary nipples that actually remain after birth, and actually are not considered abnormal per se, but just something to be aware of. And the thing is, and they can occur in both men and women, not just women. Epithelial cells at any point along this milk line have the potential to develop into mammary glands. And when they do occur in other locations other than the normal location, they're called supernumerary nipples or breasts. Most commonly, it's nipples, but again, it can occur anywhere on the milk line, all the way from the axilla, all the way down to the groin. Now, at birth, the breasts are undeveloped, and they're exactly the same for both male and female infants. Now, it's the hormones that help to stimulate the growth of the breast tissue. It's important to know that in males, they only have a ductal system, basically. The lobular system, the acinar structures in the males actually undergo degeneration and don't persist after birth, after fetal life. So in males, you only have a ductal system. In females, you'll have both the ductal and the alveolar system, which undergo proliferation and enlargement in response to the estrogen and progesterone, which is key to the development of breast tissue in females. So at puberty, for females primarily, the ductal system matures, and that's because of estrogen mostly. Fat deposition starts to occur in the breast. I don't know if you know, but breast tissue is actually made up of mostly fat tissue. And yes, there's ductal structures and lobular structures that are throughout the breast tissue, but most of the tissue that surrounds those elements is fat. Now, the areola and the nipple undergoes pigmentation. The nipple undergoes growth and pigmentation. And again, this is all due to estrogen. Now, in adolescence, you start to get more progesterone. Again, this is because at the same time, the ovaries are developing too, and they're starting to help produce progesterone. And this progesterone actually works on the terminal units, the lobular units, the lobules that kind of branch off of the ducts that are formed of acinar glandular structures. Those are the units that will eventually form secretory material that actually eventually forms the milk that the baby takes in after birth. Okay, So the progesterone helps to develop these acinar cells or alveolar structures, and they undergo proliferation and enlargement. And again, there's continued fat deposition and increasing size of the breast. All right, so here's some pictures. Again, this is from showing the develop. Hold on a second. Let me see something. Okay. All right, so this is a picture from Netter showing you the influence of the estrogen and progesterone. Again, notice how the ovaries have a strong influence on this because that's where we're getting the estrogens. The estrogens being formed by what cells in the ovary? What forms the estrogen in the ovary? What are the name of the cells? In what? No. Granulosa cells. Okay, you can't forget your GYN stuff now, okay? It's all related, okay? And of course, it's under the influence of anterior pituitary. And remember that there's always these negative feedback mechanisms that occur with the pituitary and the influence on the end organ, which is the ovary in this case. So yes, you have a cyst here, not a cyst, but a follicle right here that's lined by granulosa cells, and the granulosa cells are forming estrogen primarily. Now, what is this structure here? This occurs after ovulation, and what is that called again? Corpus luteum, and that's the structure that forms progesterone. Remember? So again, you have your estrogen influence initially, your progesterone influence a little bit later, and what this is highlighting is the ductal structures that are like tree branches, okay? And then the alveolar structures or the acinar structures that make up the lobules of the breast, which are like the leaves of this tree, are undergoing influence by the progesterone. So here on histology, we'll see this over and over again. This is kind of an atrophic appearing breast sample because there's not a lot of lobular development. There's not a lot of acinar or secretory units. And it's just ducts that are kind of very bland and not very active. And so this is indicative of a trophic appearing breast that you can see in childhood before puberty, or in older women who no longer have hormonal influences for whatever reason. Now you notice I know that this is from a female child because there's actually lobular units here. They're atrophic, but they're still there. In a male child, you would only see ductal structures. Now, here it is. Here's the female breast at puberty showing expansion of the ductal elements. So they're increased in number. They undergo increase in size of the lining cells, but they're normal. Okay. And then you have your lobular units starting to develop here. These are these round structures here. Again, kind of like the leaves or the grapes, you know, of a bunch of grapes. Okay, that's kind of what it's like. And then here, in mature breasts, under full hormonal influence, you get expansion of these lobular units. All right, location and size. Breasts lie over the pectoralis muscle on the anterior chest wall and are attached by a layer of connective tissue or fascia. So basically what separates the breast tissue from the lung of the thoracic cavity is a layer of fascia, a layer of muscle, and then the ribs, okay? And then basically you're into the chest cavity. Estrogen and progesterone, as I mentioned, are the hormones that control the development. Estrogen stimulating the ducts, progesterone stimulating the development of the alveoli, or the acinar cells, the secretory cells that line the acini. Now, breast size is determined by the amount of fat around the glandular tissue. Now, keep in mind the ducts and the acini are all different types of glandular tissue. So what's the most common type of tumor that occurs in the breast? Adenocarcinomas, right. Okay, and in fact, we'll be talking later today about all the different types of adenocarcinomas that are seen in the breast. Now, there's other tumors that occur too, but by far the most common is in the general category of malignant tumors are all adenocarcinomas. I mean, you can get liposarcoma in the breast. That's a tumor of fat. Okay, you can get lymphomas that occur primary to the breast. I mean, you know, whatever element occurs there normally, you may see tumors of. Not very common. They're very rare, but just so you keep that in mind. Now, important to note that the actual size of the breast does not relate to its function. small-sized breasts can have perfectly normal function, and vice versa. Now, every breast, no matter its size, has a standard anatomic appearance, and it's composed of 15 to 20 lobes. Each lobe consists of a lactiferous gland, kind of like a trunk of a tree, okay, that's connecting to other trees, so to speak. So each lobe consists of a larger lactiferous gland, which is kind of like the largest excretory duct that excretes its material directly into the nipple, right? So each lactiferous gland opens onto the nipple. And again, these secretory ducts, this main secretory is supported with connective tissue or stroma. Now, these ducts connect with all the glands, and they kind of vary in size depending upon which type it is. The lactiferous duct tends to be the larger duct, and as you go deeper into the breast tissue, as it branches more and more, and you get smaller branches within each lobe, okay, they tend to get smaller. But I just want you to keep in mind that each lobe is connected to a lactiferous gland, and they're kind of like their own unit. So it's like one tree. So think of it as like 15 to 20 trees per breast, and each one branches separately, and the trunk of the tree then it connects with the nipple. Now, the terminal ductules and acini with their supporting tissue constitute what's called a lobule. So each lobe of a breast has many lobules, many branches of the tree, so to speak, that form these leaves. Okay, so each lobule, there's many lobules within a given lobe, and that's the basic structural unit of the breast. Sometimes surgeons, they know if it like a tumor or a mass is present in a certain location of the breast, they can kind of determine that it belongs to a certain lobe. It's kind of, because they are kind of separated by kind of a thin fiber connective tissue. And when they go in and do lumpectomies, as we call them, for breast masses, they tend to take out 1 or 2 lobes of a given breast. Okay, so, and there's a way for them to be able to tell the difference on gross examination. And it's kind of subtle, but you can actually break the breast into these different segments or lobes. All right, so here's what it looks like from the anterior aspect, looking at the chest. And again, you've got your muscle layer under here is your pectoralis. You've got an external oblique that's underneath. That's kind of, you see that across the chest. And then, of course, you've got your nipple here, and then you've got each of these larger ducts here are your lactiferous ducts, the ones that connect to the nipple. Now, each lactiferous duct here supplies a given lobe of breast tissue. And you notice here that each of these lactiferous ducts have a little bit of dilated sinus here right before it reaches the nipple. So just underneath the nipple in this, what we call the subareolar location, the ducts dilate, and it's called a lactiferous sinus. Now again, you notice that you have multiple lobules here of breast tissue that make up a given lobe. So like this structure here is like all one lobe. You've got several lobules that make up this lobe, and within each of these lobules are even smaller microscopic sized lobules. So again, it's just like a branching tree. And then of course the yellow here is all fatty tissue in between. And then the white are the ligaments. Here it is from a lateral aspect to show you. This is the chest wall. You've got your rib cage here. You're seeing the ribs kind of cut in cross section. This is the second rib, first rib. Here's the clavicle. And then, of course, you've got muscles and ligaments between the ribs. Here's your lung tissue. Here's the pleural surface right here, visceral and parietal. And then, of course, this main muscle here that underlies the breast tissue is pectoralis major muscle. And then, of course, the breast tissue, you've got mostly fatty tissue here. You've got your ducts, your lactiferous ducts, your lactiferous sinuses that are little dilated areas. And then each of these lactiferous ducts are supplying a lobe of breast tissue that's made up of multiple lobules. And then, of course, here's another diagram of that. Again, muscle fatty tissue, breast tissue, made up of lobes and lobules and ducts that connect to the nipple. All right, so the size of the lobules vary. And again, a lot of it is due to the functioning of the breasts. They're largest during young adulthood and contain numerous ducts. After menopause, again, when the hormonal influences decrease, the lobules decrease in size and may only be composed of a few ducts. Now, the secretory duct of each lobe, and again, remember the lobes are made up of multiple lobules, leads into a separate duct system that does not communicate with neighboring lobes. So keep that in mind. Remember I said the lobes are like, each lobe is like its own tree, and they don't really connect with each other. But there's 15 or 20 of them that do connect and to the nipple through the lactiferous ducts. So how many lactiferous ducts are on the nipple? 15 to 20, right? Okay. So, and again, this type of existence is very important to the overall breast function and also for identifying where lesions are in the breast in some cases, if you're getting nipple discharge and whatnot. The nipple is a raised structure surrounded by the areola. It contains numerous ducts and mucus glands that open to the surface. Now, what covers the nipple? Does anyone know? What's that? That's right. It's like skin, basically. It's stratified, keratinized, stratified squamous epithelium that covers the nipple. It's interesting. We don't get a lot of, you know, again, it's squamous, but we don't get a lot of, in fact, I don't recall the last time I saw a squamous cell carcinoma arising from the breast. It's very uncommon, okay? But maybe there's some protection, you know, from the rest of the breast tissue, who knows? But there are certain tumors that do occur in the nipple, and one of them is, and you've actually seen it before in the GYN tract. In the vulva? Does anyone remember what type of tumor can actually involve the nipple that we're going to study a little bit later? Anyone? Paget's, that's right. And you saw Paget's in the GYN tract. And that's again because of that, remember, there may be a connection to the fact of that milk line structure, all right, of seeing some similar tumors. All right, so a short distance beneath the nipple orifice, the ducts from each lobe dilate to form a small reservoir. I called it the sinus before, the lactiferous sinus. It's also known as the ampulla. So kind of equivalent terms here. It just means a dilated area that is kind of like a small reservoir that's actually used to store lactation secretions when needed, okay, for the baby. I mean, it's not a huge storage area, but it stores a little bit. The areola is a pigmented area that surrounds the nipple, and it contains a large number of sebaceous glands that actually give it its, you know, sometimes you see little pinpoint areas that look yellowish in color, yellowish to white. That's because there's sebaceous glands there. There's lots of them. And I mean, they're normal sebaceous glands. They're just more prominent in the areola. And in the areola, we call them the glands of Montgomery. Again, all they represent are kind of proliferation of sebaceous glands. And they appear as small nodules that are tan to yellow immediately underneath the skin. All right, again, areola, as we mentioned already, the histology. Areola and nipple are covered by stratified squamous epithelium. The ductal orifice has a little bit of stratified squamous epithelium for a very short distance into the lactiferous duct, and then it becomes glandular. And then it's glandular the rest of the way. And just like other sites in the body, those ducts, the larger ones have more columnar epithelium, and as they get smaller, the epithelium gets shorter and more flatter, and so it becomes more cuboidal, just in the smaller ducts. And their function does vary according to the hormonal stimulation. So here's some histology of the nipple. This is actually a cross-section of the nipple. Whenever we get a mastectomy specimen, which, by the way, is not all that, it's not all that common anymore because they do a lot of conservative surgical therapy for tumors, which in what we call lumpectomy, you know, which is a kind of taking out a segment of breast tissue. But occasionally we do still get mastectomies, and when we do, we have to put in a sample of the nipple. And usually what we do is we take a longitudinal section through the nipple so that we get a picture like this, and a cross section at the base of the nipple. And what we're seeing in this cross section is that you see the stratified squamous epithelium out at the periphery, and you've got all this dense fiber-connective tissue beneath that, the epithelium. And then you have your duct openings here that you're seeing on cross-section. And again, there should be about 15 to 20 of these excretory lactiferous ducts that we're seeing on cross-section. And then you see them here longitudinally. You see these large excretory or lactiferous ducts going, up and down. And each of these ducts will open to the surface. Now, we don't always see that on the histology section because they're so thin, but you have to presume that each of these structures are emptying out to the surface here, which has stratified squamous epithelium, which beneath the surface here are sebaceous glands right here and here. There's quite a bit of it. And this looks like kind of a hair follicle here too. So that it shows normal structures that we see in the skin, except that you have ducts right beneath them. Now, secretory activity generally decreases from the acinus to the ductal orifice. So the most secretory activity is seen within the acinar structures that make up the microscopic lobules of the breast tissue. Again, the ducts function in carrying and storing secretions, not making the secretions. The acinar cells are the ones that produce the secretions. So the ducts, they're lined by this columnar epithelium, and the acinar units are also columnar, sometimes cuboidal, depending on the function, on its hormonal state, but they're secretory. So there's differences in these columnar epithelium. One is secretory, one is not. Now, as I mentioned, the ducts, the sinuses, the ductules, they're all lined by these columnar cells that can be simple cuboidal in the more terminal locations. That means in the smallest lobule, they tend to get smaller, and they're referred to as the terminal ductules that kind of open up within the lobular unit. Because remember, the acinar structures are emptying their contents into these small terminal ductules. So let's look at some normal histology. Again, this is looking at the microscopic anatomy of a small portion of a given lobule making up a lobe. Okay, and again, these are the end units. And what we see here, these structures here are the ducts. This is a normal duct, and off of this duct are branching structures that are called each one of these structures here, these round structures, are called a lobular unit. And within this lobular unit are multiple small acinar structures. Those are the secretory units. Okay, so each acinar structure is composed of a secretory columnar cell. And these acinar structures empty into small terminal ductules that connect with this ductule right here. Now, one of the important cells to be aware of, because this is going to help you in telling whether it's benign or malignant in some cases, both on histology and cytology, is the presence of myoepithelial cells. Myoepithelial cells are very important. They actually line the ducts. This is another, did I skip ahead? Yes. So each of these ducts here, and within and surrounding the acinar units as well, are structures called myoepithelial cells. Now, why are they there? Well, remember that when you put in the myo in there, it means that there's some kind of muscle origin. And what happens is that epithelial cell has these contractile fibers that will allow the secretions to move throughout the duct system. So they're important for allowing those secretions to move. And so all of these epithelial cells will have at their basement layer a layer of myoepithelial cells. And we can see that on histology in most cases, but we identify them often with some special stains when necessary. And these myoepithelial cells often stain with things like they have smooth muscle origin. Smooth muscle actin will stain them. Calponin is one you've not heard of before, is another one that stains myoepithelial cells. Smooth muscle myosin, which is a more specific one than smooth muscle actin. So we actually use these in histology to determine if they're present or not, because their absence may indicate the presence of cancer. Okay, benign ducts have myoepithelial cells. When you're losing those myoepithelial cells in areas of ductal proliferation, may indicate the presence of cancer. So that's why it's invasive cancer, and that's why it's important. Now, again, I mentioned to you that the majority of the breast stroma is actually composed of fibroconnective tissue and fatty tissue or adipose tissue. Here's another normal breast duct. Again, this duct is actually a little bit dilated, and that's not uncommon for them to be a little bit dilated and filled with some, these are all foamy macrophages and maybe some inflammatory, some chronic inflammatory cells that are in there, and we'll normally see a little bit of those, okay? But notice the duct lining here. Sometimes it looks like it has 1 to 2 layers of columnar cells, and that's normal. There's a basement membrane out here, and then we occasionally will see smaller, more oval-shaped nuclei that tend to be a little bit darker. It's supposed to be anyways, like right here and here. And those represent the myoepithelial cells. Here it is on higher power. It's a little bit easier to appreciate some of the individual cells. Now notice that these are all columnar cells, and they look like they can be anywhere from 1 to 3 layers thick. I mean, classically it's 1 layer. Sometimes it'll look like multiple layers just because of how it's cut in the tissue section, you know, but each of these columnar cells connect to the basement membrane. Notice that the nuclei are oval in shape and pretty regular from cell to cell. They sometimes have these little apical tips on them. That's, you know, just the normal cytoplasm, and because it has some fragility to the surface, it looks like it's being pulled off from the cell surface. It's not cilia, but it's little apical snouts that we can sometimes see in the normal cells. But the other cell I want to point out here are these cells that are, now again, these cells are oriented perpendicular to the basement membrane, but then you notice these smaller cells at the base that are kind of oriented with the basement membrane, parallel, and those are the myoepithelial cells. Their nuclei are a little bit smaller. They tend to be a little bit more hyperchromatic, but they're very bland, and those are myoeps. And they also, on histology, we tend to see vacuoles. This is not uncommon. We don't see that on cyto, but you're going to learn to recognize myoeps very well on cytology. It will help you in making interpretations. All right, here's a normal breast lobule. Again, sometimes this is referred to as a terminal duct lobular unit. It's the smallest microscopic unit of the breast. And again, it's composed of acinar or secretory units as well as the smallest terminal ducts that then connect to the lactiferous, you know, the larger excretory ducts. And then, again, these are pretty uniform throughout. You see these acinar structures throughout. You'll see myoeps surrounding them. And these are secretory type cells. Sometimes we'll see a little bit of chronic inflammation in the stroma in between these glandular acinar units, and that's normal. And then notice the rest of the breast is just connective tissue, pink connective tissue, and fat. Again, here's the representation of all these different breast tissues. This is as we're going towards the nipple and the ducts get larger. They tend to have more of a columnar type lining. As we get to the smaller lobular units, they get flatter and more cuboidal. Here's a terminal duct. Here's a lobular unit composed of all these small secretory acini. And these are representing the myoepithelial cells. They have more of an oval shape to them. All right, any questions on that histology? And we're going to see ductal cells again. Probably the two most common cells you're going to learn to recognize today are the ductal epithelial cells and myoepithelial cells. All right, those are going to be key. Lymphatic drainage. Now the breasts have lots of lymphatics, and it's important for treatment of breast cancer, knowing where the tumor may proceed through the lymphatics and where it will drain to. Most of the lymph nodes of the breast are in the axilla, and that's where we find most of the lymph nodes that become involved with breast cancer, regional lymph nodes. But there's other lymph nodes along the internal mammary chain of the chest wall, and some other areas deeper into the surrounding the pectoralis. But again, the superficial lymphatics are most commonly the lymph goes to the axilla. Now again, 85% of lymph from the breast enters the axillary lymph nodes, as I mentioned. I didn't mention 85%, but now you have the percentage. And there sometimes is normally this little tail of breast tissue that can also extend up into the axilla. It's called the axillary tail extens. And you don't want to confuse that with lymph nodes. If a woman gets a mass in the axilla, you want to make sure that that's not breast tissue versus a lymph node. And there's differences in how those are approached. Now, again, some of the other lymph that I mentioned to you will go into what's called lymph nodes along the peristernal area of the chest, and that's referred to as the internal mammary chain, and they occur on both sides along the lateral edges of the sternum. Here's an example of all the different lymph nodes that can drain the breast. The blue represents all the different lymphatic channels that are normally seen throughout the breast tissue. You've got your internal mammary chain here, as I mentioned, the one that curves along the peristernal border. You've got some higher up are some supraclavicular lymph nodes. And then over here are your axillary lymph nodes. Now, on average, if we get a full axillary dissection now for a patient with a mastectomy, you know, I have to tell you right now, they don't often do full axillary node dissections anymore. Does anyone know why? Or any knowledge on that at all? Because what they do now, and we'll talk more about this later, is what's called a sentinel node procedure. Sentinel node means first, and basically refers to the first draining node. So what they have found is that if they can identify that sentinel node for a patient with breast cancer, what they do is they inject radioactive type dye into the tumor mass right at the time of surgery, right before surgery. And they look to see where the dye goes to first. And they use gamma, it's a kind of gamma radiation that they use. And they use a gamma counter to try to determine where it is. And once they identify that sentinel node, they take it out. And if it's negative, then they don't do anything else. Because usually, if that sentinel node, the first node that's going to be positive, most often it's going to be that sentinel node. And if it's negative, they have found that that represents the rest of the axillary tail, and they don't have to take out any more nodes, which is really a good thing for the female getting treatment for breast cancer, because if they have to do a complete axillary node dissection, what happens? They don't have that good axillary drainage system anymore, and arms often get swollen and uncomfortable because without that drainage present. So it's actually a very good thing that they've been doing this for almost 2 decades now, this limited sentinel node procedure, and they found it's very, very effective at identifying the positive nodes. And if they're positive, then they got to go back in and do the rest of the dissection. But we find that most of the nodes in breast cancer, probably 75 to 80% of the time, most often the axillary nodes are going to be negative. But it is a key prognostic feature for breast cancer patients. And we'll talk a little bit more about that later, too. All right, so again, hormonal, we've talked about the hormonal effects a little bit already. During the proliferative phase of the menstrual cycle, the breasts are stimulated by estrogen. During the secretory phase, progesterone and estrogen act on the tissue and produce both ductular and acinar development. Those are your secretory cells within the lobules. Again, pituitary prolactin appears to act directly on the breast to stimulate and regulate lactation. And here's some examples. Again, we saw this earlier. It's the same thing, again, highlighting the estrogen and progesterone effects on the developing breast tissue. Again, what's the main function of the breast? Well, for lactation, right? All other discharge that occurs from a nipple is abnormal. Remember that, ladies. If you ever get a discharge, or for your wives, okay, if you ever have a discharge, you need to get it checked out. Okay. because any discharge other than lactation is abnormal. Well, sometimes you can get some, fluid that leaks from your nipple. It's usually a little bit. It's not like, lactation type, but sometimes it can be clear. Sometimes it can be bloody looking. Sometimes it can be infected if you have an infection in the breast. Now, of course, you usually know that for other symptoms, but because infected breasts and nipples often are very tender and uncomfortable. But other discharge may not show any other symptoms except for the discharge. When they're bloody, that actually raises a red flag. Bloody discharges are more abnormal than clear discharges. So just keep that in mind. They don't occur very often, but they can. And it's just something you need to get checked out. Now, lactation mechanisms. Now, there's a lot of hormonal influences here. Estrogen helps to promote breast development and inhibits the anterior pituitary secretion of prolactin. And that holds it off, the lactation until the baby is born. And then the presence of suckling on the nipple then immediately stimulates the production of prolactin. And then also, at the same time, the posterior pituitary secretion of oxytocin. So both the anterior and the posterior pituitary gland are very important here. Prolactin will stimulate lactation, and oxytocin helps to stimulate the alveoli to eject milk into the ducts. So in other words, it helps to stimulate those myoepithelial cells to allow the secretions to be ejected into the ducts. All right, so here's some examples. Again, you've got all your hormonal influences here, including the placenta, which will have some influence, as well as your pituitary gland. During pregnancy, the breasts do get enlarged and tender and full, and they remain that way more so during lactation because the tissue becomes quite proliferative, quite active with all this activity that's going on to help produce the appropriate secretions. And you notice here, this is a lobular unit that shows a lot of glandular proliferation. The secretory cells become enlarged, they become hypervacuolated because of all the secretory material, and the lumens of these acini become filled with secretory material that eventually makes its way into the ducts for lactation. Here's an example on histology of a lactating breast lobule, and compare this to ones we saw normally earlier, and you see they're quite large, quite proliferative. You've got your terminal duct in the center here, and then you've got all these secretory units that are quite hyperplastic and proliferative looking. Benign, okay, but quite proliferative, and that's important for its activities. Here it is on higher power, and you can see how these cells get quite large. They have abundant cytoplasm that becomes vacuolated. They have nuclei that become larger with prominent nucleoli. I mean, basically it's showing proplastic changes because of all the activity. And you'll see this important to know about this because you'll see these kind of changes on cytology sometimes, these lactating changes that we'll talk about later. And you don't want to confuse it for cancer, okay, because there's prominent nucleoli here, and these nuclei are enlarged. And we'll talk about making the distinction later on, but just so you know. All right, we already talked about this a bit, so it's just a little bit of a review. At birth, the infant breast actually is slightly prominent due to the maternal hormones. And in fact, right after birth, upon the immediate withdrawal of the maternal hormones, the nipples from the baby often secrete have a discharge, and that's normal. It's not abnormal. And they call it witch's milk. I know it's a horrible term, but it's just a normal thing. Okay, it's just a normal thing that occurs after birth, and then eventually after the hormones dissipate, which takes a few days, that stops. Again, the breasts remain in an undeveloped state throughout childhood with absence of secretions. Now, at adolescence in females, there's gradual development of both the parenchyma stroma. At reproductive age, you get your greatest cyclic hormonal influences. And of course, at pregnancy, the ducts proliferate and become very prominent. They can even show papillary formations within the acinar and ductal elements. And you tend to get lots of fat droplets and lots of cytoplasm in those secretory cells that make up the acinar units. Postpartum, you tend to get a lot of epithelial cells that are discharging into the fluid. The initial fluid is called the colostrum. It's a thin, cloudy fluid that's secreted a few days before the true milk is lactated. It actually takes a few days for that to occur. But they say that that initial colostrum is actually the healthiest for the newborn. It has a lot of good nutrients and a lot of good antibodies that's important for the newborn's immune system. And so you tend to get epithelial cells that are kind of shedding as a whole cell within that fluid, and that's called holocrine secretion. Remember that from histology lectures. Now, during the postmenopausal state, there's gradual atrophy because of the withdrawal of hormones, and what you see is regression and involution of the ductules as well as the acinar units. But the tissue still remains responsive to hormones. If then that person would then take hormones, it would probably show some development again. All right, so we've talked about the anatomy, the histology, the function, and the life cycle of the breast tissue. So now we're actually going to go on to the lesions that we see in the breast tissue. And there's a variety of lesions that can occur. This is just a basic diagram showing you again. Here's the nipple, lactiferous duct, lactiferous sinus, a lobe of breast tissue, your acinar and your smaller ductules that occur most distally. And again, there's different things that will affect in different locations of the breast. At the sinus area or in the subareolar area, which means beneath the areola, you tend to get what's called nipple adenomas. On the nipple, you can get Paget's disease. In the larger ducts, like the lactiferous duct, is where intraductal papillomas like to occur. But it's in the more distal locations where you get your other lesions, both benign and malignant. And we're going to talk about those beginning now. Now, first of all, we're going to start with the benign non-neoplastic conditions, and then we're going to do the benign neoplasms. Now, probably one of the most common non-neoplastic conditions besides fibrocystic change, actually probably fibrocystic change is the most common abnormality seen in the breast. It's benign, it's non-neoplastic, okay? So it's one of the most common that we see. Probably second to that is a mastitis. And this occurs often in the postpartum period associated with lactation. The nipples can get quite irritated from the suckling activity, and Staph aureus and streptococci, which occur on the skin normally, can infect the area, and this can cause a acute inflammatory response, which if it gets to us, at some point, if it is truly infected, needs to be treated with antibiotics. And when they heal, it may cause some scar tissue. Now, this is an entity that tends to occur in older patients. It's called mammary duct ectasia. It's kind of a conglomerate of different things where you get dilation of the ducts. So remember this word ectasia. We use that in histology. We use it in this condition, obviously, but basically ectasia means dilatation of the ducts. And so you get this abnormal dilatation of the ducts, and then you get some breast secretions that become inspissated within those ducts that sometimes become obstructed. So the secretions kind of stay there, and they'll form little cystic areas as well. Fibrocystic change kind of will do a little bit of the same thing as well. But in response to these dilated, irregular ducts, you get this chronic inflammatory response that often shows that can show granulomas. And plasma cells are often seen in this setting more than some of the other inflammatory conditions. So, but again, it has a predilection to occur in older patients. Now, here's a patient with bilateral painful enlargement of the breast that are also erythematous. So erythema tender, this is indicative of an acute inflammatory response, in this setting, acute mastitis. And if it's not treated appropriately, it can form abscesses that can then form scar tissue, and it can be pretty nasty. But usually it's recognized fairly soon because it's not a very comfortable condition and it's treated appropriately. And what do we see on cytology? I guess this is the best way to demonstrate mastitis, is neutrophils and necrotic cellular debris, just like we would see pus anywhere else. So if you do an FNA on a breast and all you see is this picture, you know, two things to think of. One, acute mastitis, or two, you got into a tumor that's all necrotic, because they can also get necrotic. But this is very classic for acute mastitis. If I see this on an FNA, I usually will then put a sample in for culture, because, culture and sensitivity is going to be key for the treatment of these patients. Although, like I said, they're mostly streptococci and staphylococci, which are usually treated with a cephalosporin, broad spectrum oral cephalosporin, if it's not too bad of a condition. All right, what about fat necrosis? Remember, there's a lot of fat in the breast, and so one thing that can happen occasionally is that the fat becomes traumatized in some way, and it will show some necrosis. Now, this fat necrosis can be seen in patients who've had prior biopsies, and I've seen that. We see that lots of times. We see evidence of fat necrosis, but fat necrosis can occur in patients who've injured their breast for some reason. They were in an accident, they fell down, they hurt the breast tissue, or they were. Sometimes it's seen in extreme joggers, who don't have very good support for their breast tissue, and sometimes they can get that too. Now, the key with fat necrosis is that you want to make sure it's not cancer, because it can actually form a very prominent, palpable, hard mass that kind of resembles cancer on clinical exam as well as on mammogram. So they often need to be biopsied or FNA'd to kind of make that distinction. But basically, it's an inflammatory reaction. It's occurring to the fatty tissue that had gotten damaged for whatever trauma that occurred to the breast, whether it was a prior biopsy or some kind of accident. And what it shows is the fat kind of degenerating and surrounded by mixed inflammatory cells and lipid-laden macrophages. Sometimes it becomes hard to tell what's the degenerating adipocyte versus the lipid-laden macrophage, because they can look very similar. But usually you'll notice the adjacent fat tissue, and that will give you a clue. And when it heals, it can be replaced by scar tissue. Here's an example on histology, and again, you see lots of fatty tissue here that looks relatively normal here, but then when you get down to this area, there's a lot more fibrous tissue in between, and there's a giant cell here, multinucleated giant cell, probably a histiocyte here and over here. There's actually quite a few of them around, and then a few chronic inflammatory cells. So what this is indicating is the fat is degenerating for some reason, and when it heals, it can form scar tissue. Here it is on a higher power, showing you again lots of foamy macrophages and lots of chronic, mostly chronic, although there's a little bit of acute inflammation in the background. Now, what about silicone? Now, silicone is not usually used in implants anymore. I think it's not allowed by the FDA, but there are still patients who've had silicone implants placed before, and silicone has caused a lot of trouble for some of these ladies, especially when they leak, which they can do. Even if it's not a big rupture, you can sometimes get these microscopic points of leakage through the implant, and the silicone is not particularly good for the adjacent breast tissue, and we can actually recognize it in certain regards. Here's an example. The silicone is a foreign substance, so what's it going to cause? Inflammation and granulomatous response, because it's a foreign substance. And so what we see here is breast tissue that's undergone a lot of scarring, so it's all this fibrosis. You've got what looks like fatty type globules here, and then you've got these multinucleated giant cells throughout, filled with these large vacuolated structures here that are acellular. What these vacuolated areas actually represent is where the silicone was. What happens during formalin processing is it kind of washes out the silicone, and what you see are just the spaces where the silicone deposits were located. Now, on cytology, which doesn't go through that formalin processing, at least some of the preps, you'll sometimes see this material show up as kind of this very clear, refractile type substance. It's you can kind of make it out a little bit, but once you've hit it with formalin, you know, you're not going to really see it. And what you see are these spaces that you where the silicone used to be, including in here within these multinucleated giant cells. But the thing is, because of all this inflammation, it causes a lot of scarring, and that can be a problem too. All right, so we've talked about the benign non-neoplastic. Oh, we are talking still about the benign non-neoplastic conditions. And one of the most common ones that occur in the breast is fibrocystic changes. It is the most common disorder of the breast tissue, okay? When you're looking at all things that involve the breast, benign or malignant, non-neoplastic or neoplastic, it is the most common disorder of the breast. In fact, well, you know, they don't do a lot of surgical biopsies anymore. They do a lot of core biopsies to demonstrate these, but it, in general, accounts for about 50% of all procedures that are done on the breast is due to fibrocystic change, causing some kind of palpable mass or abnormal microcalcification in the breast tissue. Now, it's most commonly seen in young to middle-aged women, 20 to 40 years of age, usually related. You notice that's because that's when most of the hormones are cycling, okay, because it tends to have a hormonal association. It's frequently bilateral. It has been found that oral contraceptives actually decrease the symptoms and the incidence of the disease, because what do the oral contraceptives do is they tend to stabilize the hormonal levels a little bit, and it helps. It's actually often used in patients who have symptomatic fibrocystic change. They often recommend that they get treated with oral contraceptives as a treatment for the disease, because it has this association with hormonal imbalance, either an excess of estrogen or a deficiency of progesterone. Now, the fibrocystic changes I mentioned can produce a mass that needs to be differentiated from cancer. And one other important thing to be aware of is that, you know, most fibrocystic change is of a simple standard variety, but there's actually some that will show hyperplasia of the ductal cells. We call it epithelial hyperplasia, sometimes proliferative breast disease. And when it gets, and sometimes it'll be a little bit atypical. And if that's the case, if there's all this hyperplasia with atypia, it actually is felt that it increases the patient's risk of cancer. So in a sense, it increases the risk, although if you have it, it doesn't mean you're going to get cancer, but it's considered a higher risk condition in a patient who has it, and usually those patients will be followed a little bit closer. All right, so here's some examples on both from Netter regarding fibrocystic changes. We usually recognize it clinically because they tend to, again, they can cause multiple nodules throughout the breast, some that are smaller, some that are larger, depending on how large the cysts are. Sometimes these multiple nodules kind of feel like a granular swelling to the breast, and that's what he's trying to highlight here. Now, when we look at the breast on cross-section, what we see here is here's the normal breast tissue up here. Here's the fibrocystic breast up here. Now remember, what does fibrocystic mean? You have fibrostroma and cystic dilation of breast. So fibrocystic. And so what we're seeing here is fibrostroma surrounding multiple tiny cysts. Now, often when they get this large, these cysts get filled with fluid. They often take on a blue color to their surface on gross examination. And why is that? Because these cysts are lined by vessels, okay? And when they get filled with fluid that sometimes is a little darker in color than serous, they tend to look a little darker, and they'll take on this blue hue to them when they get that large. And these are pretty large. When you can see them like this with the naked eye, those are pretty good sized cysts. Those are macrocysts, all right? And here they are on histology, again showing you the cystic dilation of the ducts and a lot of fibrosis surrounding them. And all this fibrosis kind of distorts the normal lobular architecture. You know, it doesn't have that nice you know, branching tree-like pattern and round lobules anymore. It just kind of distorts it. Again, here's another example of a very large blue dome cyst, okay, and that cyst is filled with fluid. They can get kind of tender when they get this large, and doing an FNA is actually treats it, because the FNA will remove the fluid and help relieve some of the pressure in the cyst. So sometimes we do FNAs in these lesions, and the surgeons do this too. They just stick a needle in it. I mean, you can pretty much tell when you, after enough experience in palpating breast lesions, whether something is cystic or not. And so once they feel that it's cystic, they'll put a needle in it and drain it, and that will help relieve some of the symptoms. If it doesn't drain completely and there's still a residual mass there, then they often go back and will consider biopsying that area, because you want to make sure it's not something else, you know. Because cancers can be cystic too, right? So you always got to think about that. But yeah, this is that's a huge cyst. They don't usually get that large, but when they do, that's what they look like. And here it is on cross section, showing you how large some of these cysts can get, surrounded by all the scar tissue. Again, it's a fibrocystic change, the most common type of change associated in the spectrum. It presents as an increase in fibrostroma associated with ducts that are dilated, that can become so dilated they fill with fluid that makes it into a cyst. And these cysts will vary in size. The cysts are filled with a variety of fluid that can look either serous, can look turbid, it can look bloody, it can look inflammatory, which kind of makes them appear blue domed. Now on histology, these cysts are lined by epithelium that's either cuboidal to columnar, depending on how flattened it got from all the cyst fluid that might be in there. But one of the other things that tends to occur in ducts that have undergone this dilation and have all this fluid collected in them is something called apocrine metaplasia. That's another thing that's unique to the breast that you're going to learn a lot about on cytology. So what happens is the ductal cells become metaplastic and take on this granular appearance to their cytoplasm, and that's called apocrine change or apocrine metaplasia. And when we see apocrine metaplastic cells both on histology and cytology in the setting of all these other changes, that's just another feature of fibrocystic change. So that's something you'll learn to recognize very well. All right. So I mentioned to you earlier, there's different spectrums of fibrocystic change. There's simple fibrocystic change, and then there's more proliferative fibrocystic change that shows hyperplasia. But first of all, let's talk about what's most common. That's the simple fibrocystic change, and it shows on histology cyst formation, both small and large, fibrosis of the surrounding stroma, epithelium that shows in the ducts that shows apocrine metaplasia. So you'll see these cysts and ducts lined by this eosinophilic granular cells. Okay, you'll see in a moment. You often get some chronic inflammation outside the ducts. And then the ductular units can also show varying degrees of hyperplasia, as well as the lobules, but it's usually to a mild degree in this setting. We sometimes refer to that as usual ductal hyperplasia, or UDH is a term that's often used. And then the other thing that can happen is what's called adenosis, which actually means, you remember, epithelial hyperplasia refers to the epithelial cells lining the ducts showing hyperplasia, but adenosis refers to the acinar units becoming more proliferative within a given lobule. So there'll be more secretory elements in a given lobule. That's adenosis. All right, here's a gross appearance of a blue dome cyst on a biopsy specimen. Here's fatty tissue surrounding it. And it's actually not that blue. The background is blue, but it's really just a very good example of a macrocyst occurring in the setting of fibrocystic change. We don't really see this in cancer, these kind of cysts that have these smooth lining that you see here. It almost, I mean, it's a very thin wall, and I dare say you just put a little nick in that thing and all that fluid is going to come out, okay? But it's a very thin wall, very regular, very smooth, and that's all important and kind of distinguish it from other, from bad things. All right, here it is on histology. Now again, that cyst right here would most likely look like, when you cut it on histology, will look like one of these structures right here. That's about it, okay? And you can see these actually all represent cystic dilation of the ducts. When you look closer at the lining here, you'll see the columnar epithelium or cuboidal epithelium that makes up the ducts. Now you also have some calcifications over here, which you can see within the cyst as well as in the other epithelial elements. Here you've got some adenosis because some of the ducts are kind of proliferating. Here you've got some hyperplasia of the linings. So you get, and then you've got all this fibrosis in the background. Here it is on higher power. Again, you've got all these cystic structures here filled with this kind of acellular proteinaceous fluid. Now, there may be scattered macrophages in there. That's not uncommon. We call them in the breast foam cells. Okay. You'll get to know foam cells very well. What do foam cells represent? Foamy macrophages, or histiocytes, basically, that are occurring in this fluid. So remember foam cells. Now, these are normal ductal cells here. They're a little flattened. They're a little cuboidal in appearance. Then you've got these cells over here that have more abundant eosinophilic granular cytoplasm. Those are the apocrine cells, the apocrine metaplasia, which represents a metaplastic change in the ductal cells in response to all this, all these changes. Here's some more. Sometimes this apocrine metaplasia can get pretty proliferative, and you can even get tiny little papillary structures lining the ducts. Sometimes we actually call this PAM for papillary apocrine metaplasia. Makes sense, doesn't it? All right, so speaking of hyperplasia, again, we'll go through the hyperplasia and the sclerosing adenosis, and then we'll take a break before we talk about the benign neoplasms. But let's get through this part first. Epithelial or ductal hyperplasia are used synonymously. Actually, the British like epithelial, the Americans use ductal. You'll find that true in the textbooks. And then sometimes you'll see the textbooks refer to it as proliferative breast disease, kind of encompassing all degrees, all hyperplasias. Now, the important thing to know is that hyperplasias that are occurring in this setting can be graded as mild, moderate, or florid, which are considered the same, or atypical. The important thing is to make sure there's no atypia. Now, mild or moderate hyperplasia is lumped into this category, also known as UDH, or usual ductal hyperplasia. And we say that because they don't have any, it usually doesn't indicate an increased risk for a significant increased risk for the patient. Again, what happens is that you tend to see more cell layers lining the ducts, greater than 2, because you can have up to 2 normally. Anything more than that indicates hyperplasia. You'll get some solid masses growing into the lumens of the ducts that sometimes form papillary structures. But the important thing is to make sure there's no atypia. And we want to distinguish atypia from the differential includes DCIS, or ductal carcinoma in situ, that's low grade. So this can become a challenge. It's nearly impossible on cytology to make this distinction. We'll talk about it later. And it becomes challenging on histology to make it. So you can imagine how challenging it can be on cyto. And a small proportion of these are considered premalignant lesions, especially those with atypia. So here's an example of mild ductal or epithelial hyperplasia. You've got increase in layers of the duct. You also have increased numbers of ducts. And again, this was occurring in a patient who also had fibrocystic change. They often occur together. Here's another one that's more florid. Now you have a duct. Here's a normal duct over here. Actually, it's showing some mild hyperplasia, but it's certainly more normal than this duct. In this duct, you've actually even got like a solid mass of epithelial cells that have undergone proliferation, but they're all benign for a variety of reasons I'm not going to go into in all that detail right now. But because when, again, the differential here includes ductal carcinoma in situ, but this is benign for a number of reasons. And so this is an example of florid hyperplasia. It's not atypical. There's no cellular atypia here. And then here's one that's atypical, ADH, as we often call it. And this one is showing nuclear atypia and crowding and hyperchromasia in these small, round, regular holes, which are concerning findings. But this kind of picture would always make me think, I want to make sure it's not DCIS, ductal carcinoma in situ. And then, of course, atypia can also occur in the lobules, the lobular units, not just the ductals. And we do have atypical lobular hyperplasia, which is also associated with an increased risk of developing invasive breast cancer. You can have sclerosing adenosis, where you get so much fibrosis in the background that it becomes really hyalinized and firm and sclerotic, and it causes a lot of distortion of the acinar units. A very hard tumor mass. It's benign, but it causes very concerning findings both on mammogram and on clinical exam. Here's an example of a lobule that is showing a typical lobular hyperplasia. Remember what our normal lobule looked like before. It would have only 1 or 2 cell layers, and it would have a space in the center, the lumen, basically. There's no lumens here, and these lobules have become more proliferative. And these are referred to as lobular cells that are showing atypia. Now, there is lobular carcinoma in situ that can also occur. It's not quite there for a number of reasons, but certainly that would be in the differential. Here's an example of sclerosing adenosis showing you large calcifications. All these large purple things are calcified material. These would show up on mammogram as an abnormal calcification, and they would do biopsies on this to identify what's going on. And then, of course, you have a lot of epithelial proliferation and sclerotic fibrosis in the background. Here's another example, very proliferative, lots of fibrosis. I don't see the calcifications here, but this always raises a red flag when we see it on histology. But despite the proliferation here, they are benign, which is a good thing for the patient. All right, so again, why do we go through this exercise on histology? And we look at all these different things when we sign out a breast tissue biopsy or a breast excision. It's because there may be some increased risk associated with development of invasive breast cancer. Now, in someone with simple fibrocystic change, there is no increased risk, okay? And that includes those folks who show mild ductal or epithelial hyperplasia and all the other things that we've been talking about. There's no increased risk. Now, when you start to get into those with moderate hyperplasia without atypia or papillomas or sclerosing adenosis, they found that those patients have a slightly increased risk. Those with atypia of either the ductal or lobular units have a moderately increased risk at 4 to 5 times. And those who have a diagnosis of in situ or intraductal carcinoma, either lobular or ductal type in situ, have a high risk of subsequent development of invasive breast cancer. And that's why they tend to be treated more aggressively. All right. And so now you know why we go through this exercise. Now, are you going to make these distinctions on cytology? No. Okay. But it's going to be important for you to understand this. And you're going to have to understand how to make a diagnosis of DCIS and LCIS versus fibrocystic change with hyperplasia. You will have to make that distinction, okay? But not to, so, you're not going to have to, as far as like mild versus moderate ductal hyperplasia, no. They usually are going to be lumped under fibrocystic changes. But it's when it starts to become atypical and when it becomes in situ, that's when you need to know how to make the distinction. All right, so we're up to the benign breast neoplasms, which includes fibroadenoma, phyllodes, and papilloma, and then after which we'll start with the cancer. So let's take a break. It's 10 of. Let's meet back at 5 after. Okay, which one do I press to pause? The middle one. So have all your other lectures been going pretty well with all the different folks coming over? Yeah, that's good. We have a new cytopathologist here this year, Dr. Kunkel. You got to meet her. I think she lectured on liver. Yeah. She's very good, very nice, and I think she's coming back to lecture again a few more times. And you notice I still have my boot on. I will first. I know I can move pretty fast with it, but I have to have it on for a few more weeks. I had to get an MRI about a week and a half ago, because it wasn't getting better, and I have 3 torn ligaments in my ankle. I'm like, and they're thinking I may need surgical repair, but I don't have an appointment. These orthopedic surgeons are very busy, understandably, and so they have a foot specialist there, Dr. Ficky, who I have an appointment with, but it's not for like 3 weeks from yesterday. So I'm counting down the days. I got to find out what's going on. In the meantime, they tell me I have to wear the boot. Okay. Doesn't slow me down that much. All right. So the benign breast tumors, the 3 main ones to be aware of are fibroadenoma, Phyllodes tumor, which is benign, and there is a malignant variety of the Phyllodes tumor we'll talk about a little bit later. And then, of course, the intraductal papilloma. Fibroadenoma is the most common benign breast tumor requiring excision. Again, it's not the most common abnormality seen in the breast. That's fibrocystic change, right? But this is the most common benign breast tumor. It's the 3rd most common lesion of the breast behind fibrocystic change and cancer. So number 1 is fibrocystic change, number 2 is cancer, number 3 is fibroadenoma. When you look at all lesions involving the breast, it's most common in patients before age 30. It's usually a discrete, freely mobile nodule that can be easily palpated in the breast. Most often seen in the upper outer quadrants, because that's actually where we see, you can divide the breast. We divide them into 4 quadrants: upper outer, upper inner, lower outer, going in clockwise direction. But they most commonly seen in the upper outer, because it's actually where we see most of the breast parenchyma in that quadrant. And actually, that's where we see most cancers, too. Okay. Histologically, it's composed, just think of its name, fibroadenoma. What does that mean? You've got fibrostroma and glandular elements, okay, that are proliferating. But what happens in the fibroadenoma is the fibrous tissue kind of causes the glandular elements to become distorted. Sometimes they can become cystic but usually they become flattened and distorted, and you have the fibrous tissue kind of forms this discrete nodule, and that's different from fibrocystic change. And so there's different types of fibroadenomas depending on how the ductal elements are compressed, basically. Here's an example by Netter to show you this discrete. It's a very discrete rubbery nodule. When I see it on gross exam, I know, we're pretty certain that that's probably what it is. It kind of almost looks like a leiomyoma that we see in the uterus, one of the uterine fibroids. But remember, this is not, uterine fibroids are smooth muscle. This is fibrous tissue and glandular elements scattered throughout. And here is, again, this is actually an intraductal papilloma. We haven't talked about this yet, but they tend to occur in these larger cystic spaces, and you get this papillary stalk of proliferating cells that are benign in this setting. All right, so here's a fibroadenoma. Again, it has a uniform kind of rubbery tan to yellowish cut surface, mostly tan. No areas of necrosis or inflammation that are evident, which is a good sign. Just very uniform, rubbery, solid cut surface, and smooth, very smooth edges to it, very discrete lesion, and that's all good benign findings. And here it is on histology. Again, you see the normal fatty tissue out here, a fibrous capsule. You don't always have a capsule, but that's definitely a capsule. And then you've got the tumor over here showing you this kind of edematous stroma, kind of compressing these ductular glandular elements and kind of just flattening them out. But very discrete lesion, all benign. The other tumor that actually shows another biphasic appearance. Now, when I say biphasic, I mean it has both stromal and epithelial components. A fibroadenoma is a biphasic tumor. Here's another type of biphasic tumor, but in contrast to fibroadenomas, the stromal component tends to get more cellular and tends to overgrow. So that's how it's distinguished from fibroadenomas. It has a more cellular stroma. It has the same looking glandular elements, but more cellular stroma. And it tends to occur in older patients. They can get very large, and there are malignant forms. And when they're malignant, they're called, also referred to as cystosarcoma phalloides, because the malignant component, which is defined by the stroma looking malignant, looks sarcomatous. It looks like a sarcoma. That's why it's called that. Now, grossly, the reason, where does it get its name phalloides? Well, phalloides is actually a Greek word, I believe, for leaf-like. And that's kind of what it looks like on histology. It forms this kind of leaf-like proliferation, and due to the overgrowth of the stroma. Now, the malignancy is defined by appearance findings of increased cellularity, pleomorphism, anaplasia, and mitotic activity. So the benign ones don't usually show the anaplasia and the mites, but the malignant ones do, and they will behave like malignant tumors and can metastasize. Here's a benign one. They tend to be larger than fibroadenomas. This one is 5 centimeters, so this is a pretty large excision. But this is the tumor mass right here. It's pretty easy to make out. This is all ink. Here we always ink breast tissue when it's excised, because we always want to know if there's tumor at the margins, or if the surgeons want to know that. Okay, and so it's important to always ink a breast tissue. Now this is what I mean by leaf-like proliferation. On low power, you see how the stroma has overgrown this lesion so much that it causes this kind of leaf-like appearance to the lesion throughout, and then you've got your ductal elements kind of lining it here and also inside it. Now this one is malignant. This one is benign. It's not too cellular, although there is some increased cellularity. It doesn't show any necrosis, myxoid change, and trust me on this, on low power it showed no mites. Okay, so it's benign. But this one is malignant. On higher power, you appreciate the fact that the stromal component looks pretty anaplastic and pleomorphic, and it's easy to find mitotic activities. When you see that, that should always raise a red flag. So it's kind of like, if you remember from the uterus, you know, there you can get what's called adenosarcomas, which means benign glands, malignant stroma. That's kind of like what this is. It's basically a malignant stroma here with benign glands. It's called a malignant Phalloides tumor, or you'll see the term, and it's appropriate to use as well, cystosarcoma phalloides. Now, what about intraductal papilloma? It's basically, by definition, what's happening is a papillary growth within a duct that's often dilated and cystic. These tend to be solitary lesions. They can get pretty good size. They tend to occur in larger lactiferous ducts, and one of the most common presenting signs is a bloody nipple discharge. And you can identify these lesions often on mammography, and they usually undergo a biopsy then. Now, the greater complexity of the papillary architecture, these lesions and the hyperplasia that can occur, again, they have a higher risk for subsequent development of invasive cancer, but they're not cancer by themselves, you know, without that complexity. Here's an example of an intraductal papilloma on histology. Again, you've got other fibrocystic changes in the background, including a cyst right here and stromal fibrosis. But then you have this very dilated duct here filled with this proliferation of finger-like projections. You know, papillae most often have fibrovascular cores and will give you this kind of complex arborizing pattern that you see here. But again, to call it benign, I want to look at it closer and make sure those cells are not cytologically atypical. Here it is on higher power, speaking of which, okay? And here you've got, you know, this is a papillary structure. It's got a fibrovascular core filled with blood, lined by epithelial cells that are a little bit hyperplastic but bland. There's a few myoeps scattered about, which is a good benign feature as well. Now these things do tend to be bloody. They tend to, because of their complexity and their arborizing vascular pattern, it's not uncommon for them to have that, to cause this bloody secretion, which can form a bloody discharge. All right, so done with the benign, on to the malignant. All right, so everyone recognize what date this was obtained, this Time magazine? The golf, 11th hour diplomacy. You probably all were in elementary school of it. Okay. What? Yeah, this was January 14th, 1991, right? That's about when the first Gulf War took place, right? Okay. Anyways, what? All right, so this was the time cover. At that time, they were showing this kind of thermal type procedure that they really don't do, and they don't do this now. But actually, what it's been replaced with is MRIs when they need to do something better than mammogram. But at this time, it says 1 American woman in 10 will get breast cancer. Actually, that number's gone down. It's now closer to 8 or 9. Okay, so it's a very common disorder. It is the single most common cancer diagnosed in the United States women, second most common cause of cancer-related deaths. What's the most common? Lung cancer. That's right. So although breast cancer is the most common cancer, even more than lung, it doesn't cause as many deaths, thankfully, as lung cancer does. Okay. Now, what are the risk factors for breast cancer? Well, being a female. Okay. It's more common in female, although men do get breast cancer. They got ductal elements in their nipples. They can get breast cancer, but it's about a 1 to 100 that they get it, okay? And compared to females. Age, the older you are, the more likely that you can get breast cancer. Family history is important, especially the BRCA1 and 2 genetic mutations definitely put a patient at risk. And usually those patients who have been found to have these mutations actually choose to get prophylactic mastectomies because it's so common that they get breast cancer, you know. So take the breasts off. You won't get breast cancer, right? For the most part, you know. All right. Early menarche, late menopause just indicates increased hormonal exposure. Nulliparous women, for some reason. Obesity, as well as previous history of breast cancer or endometrial cancer. I also should add in there ovarian cancer. Now, patients who have BRCA1 and 2 are also at risk for ovarian cancer. And at the same time they get their mastectomy, they often get bilateral oophorectomies after they're done with their childbearing, obviously. All right, so this is from 2010. The data is roughly similar estimates this year, although actually the new data for this year hasn't come out yet. But it's roughly similar. Again, you've seen something similar before. And again, in females, breast is the most common cancer, followed by lung, followed by colorectal, followed by endometrial, and then the others listed here. But the most common cause of cancer death is lung, followed by breast, followed by colorectal, followed by pancreas and ovary. And these charts also indicate age-adjusted cancer incidence rates in the females. This is looking at a period of 1975, and males, from 1975 to 2006. And you see breasts kind of went up in the early 2000s. And I think that's because of some of the better screening methods that had come out in the decade prior. But now, thankfully, and so it was being detected more. But now it's actually plateaued and it's gotten lower, which is a good thing. Lung continues to go up, although even it has plateaued, and colorectal has actually gone down. The others have kind of remained the same. And these are cancer death rates among females for selected cancers. Again, lung, breast has gone down quite a bit because of all the good treatments that are available in the screening that has been detecting breast cancers at earlier stages, which is very important. And same thing with colorectal, you know. more screening, less cancer, right? And better treatments available. And this is for men. All right, again, I mentioned to you age is probably one of the biggest risk factors. And the older you are, the more likely you are to develop breast cancer. And you can see the differences by age. Carcinoma, for some reason, I don't know why, is more common in the left breast, just by a slight amount. Tends to occur most commonly in the upper outer quadrants of both breasts. That's where you have more breast ductal type parenchyma, as well as lobular units. Remaining quadrants are much less, and then they also can occur in the subareolar location. These are the various types of breast cancer, and basically you can break this down into, remember these are all types of all of them except for the last category here, other rare or metastatic tumors, which we'll mention briefly. Every single one here is a type of adenocarcinoma, okay? But the way we look at breasts, remember that the normal histology, you have your ducts and you have your lobules. And so you're going to get different types of cancers involving that are of different origins. You'll have ductal types and you have lobular types. And both can show either in situ or invasive varieties. So basically, those are the main types right there. You've got ductal carcinoma in situ. You've got infiltrating or invasive ductal carcinoma. You've got lobular carcinoma in situ, and then you've got invasive lobular carcinoma. So those are the four most common types, basically. Now, the other varieties that are listed here, medullary, tubular, colloid, or mucinous, which you also saw in the GI tract, Paget's, and inflammatory carcinoma, are actually all varieties of different types of ductal cancers, to be honest. They're all different varieties of ductal carcinomas, but they have unique features about them that we see both on histology and cytology that you need to be aware. And there's certain ones that have better prognosis, certain ones that have worse prognosis. Like, for instance, tubular carcinoma has a better prognosis. Inflammatory carcinoma has a very bad prognosis, okay? In fact, if you remember the staging systems for cancer, and you know that we have a T stage for primary tumor, and it goes from T1s to 4s usually. These patients usually, when you have inflammatory cancer, you're automatically a T4, okay, which is not very good. All right, so what we're going to begin with first is the in situ cancers involving ductal tissue. In fact, first we're going to talk about ductal carcinoma in situ, then a little bit about lobular carcinoma in situ, then invasive ductal carcinoma, and then invasive lobular. So, and then a little bit about the variants. So again, it's easy to kind of lump them into all those categories, and I'll help you remember them. But intraductal carcinoma, also known as ductal carcinoma in situ, or as we call it, DCIS, is most common in the 5th decade. Remember, all the other benign tumors tend to present usually in younger patients, so it's more common in older patients. And most often it presents as a non-palpable. In other words, you can't palpate it on breast exam. That's why mammograms are so important. Often presents only as suspicious calcifications on mammograms. And what it looks like is ducts that are showing a typical proliferation of the epithelium within the expanded and plugged ducts. The ducts are usually dilated and expanded and show this solid proliferation of tumor cells. Now, there is a variety of DCIS called comedocarcinoma that is an intraductal variety. But it's called comedo because the ducts, when they expand, tend to show central necrosis, giving it kind of this cheesy appearance, okay, in the center, which gives it its name, comedo, okay? That's how it's related to that appearance of the central necrotic ducts. Now, the other thing about comedocarcinoma is that not only does it have central necrosis in the ducts, the tumor cells that are out at the periphery of this involved duct are very high grade. So it's a high grade DCIS. There's low grades, there's intermediate grades, and there's high grade DCIS. Now, you're not going to have to make that distinction on cytology, thankfully. I couldn't do that, so you can't do that, okay? Well, sometimes I can, but we won't go there. But it's not necessary to to understand that. But I think it's important for you to be aware that there's different grades, and as they get higher grade, they get more pleomorphic and anaplastic. So they are going to appear a little bit different because of that. But again, if you can get to cancer and you can get to cometocarcinoma, you're doing very well. Okay. Now, sometimes the lower grade DCISs will show this cribriform pattern where it looks like the duct has little cookie cutter spaces throughout, regular spaces. And that's what we call cribriform. It looks like tiny ducts within a duct. All right, what about mammograms? This is what we can see on mammography, or what the radiologist will interpret on mammography, right? And basically all of this is normal. This is normal breast parenchyma in here. This is normal nipple. This is the chest wall. But what's abnormal is this area right here that shows these tiny little white punctate dots. Those represent abnormal calcifications. So whenever you see like a mammogram report that says suspicious calcifications, that's what they're looking at. Okay, these little clusters of white dots. And what they will do right now, whenever they see that, they'll have the woman come back to get a stereotactic guided biopsy, which means they're doing it by mammography guidance. And they biopsy that area of calcifications. It doesn't mean she gets an excision, but they'll definitely biopsy it, see what's going on. And this is what they saw in this patient's biopsy, okay? First of all, here's a normal duct over here, and you can see that there's like a one-cell lining, right? There's some calcifications in the center here of this duct a little bit. That's okay, or some cellular debris, either one. But then you have these ducts here that aren't normal, all of these. They're expanded, and then there's like this solid proliferation with occasional little cookie cutter-like holes in the center. But all of these cells are neoplastic, and what happens when they become neoplastic is they look very monotonous and they're bland, but they're monotonous, okay? And that's an important distinction from other disorders. But you've got this duct that's filled with these tumor cells. It's also got some calcification. This is why it's showing up on the mammogram, is all these calcifications. This dark purple debris right here is calcified material. And that's what's showing up in the mammography. Now, why are they occurring there? Well, does anyone know? Why are those calcifications occurring there? It actually just represents the excessive proliferation of these tumor cells, and they undergo degeneration because of that. And when they degenerate, they calcify. Okay, so it's basically a degenerative change. Here's another example. Now this was a solid pattern DCIS here primarily. This one is cribriform pattern. It's a low-grade type of DCI. So this is a normal duct here for comparison, and this is an expanded duct here. This is all one duct. It's still within the duct, so it's intraductal. It's non-invasive. That's important. And you've got all these tiny little spaces throughout this proliferation. And these are neoplastic ductal cells throughout. Here it is on higher power. Again, very monotonous appearing ductal cells, but very bland. But you can still see atypia, as in nuclear enlargement, nuclear grooves. You know, it's subtle, but there's definitely nuclear atypia there. But the key here is this very monotonous, and the other key feature is we don't see any myoapse. No myoapse within that proliferation. I didn't point that out earlier, but I just want to highlight that. That's important. All right, so here's a cometotype. Remember, this is a low-grade ductal DCIS, and these cells look fairly bland but atypical. Here's a high-grade one. This is a cometocarcinoma variant because not only are these ducts expanded by these tumor cells, but there's this extensive central necrosis here, and this is all necrotic material. And this stuff very frequently calcifies, okay? I don't see the calcifications on this example here, but it's not uncommon. And these changes will track down the ducts all the way to the nipple sometimes, okay? It can be pretty extensive. But then when you look at these tumor cells, which we'll see in another image in just a moment, they're much more anaplastic looking than we saw back here. You notice you don't really see any mitotic activity here, but when you look close at these, you will see mites everywhere. You'll see them very pleomorphic looking, just very malignant looking. So it's definitely a high-grade variant of DCIS, and this type of DCIS tends to be treated a little bit more aggressively. Here's an example with calcifications in it. So here you have a duct that's expanded by these very high-grade malignant ductal cells. And then you've got central necrosis with hemorrhage and calcifications. And that would definitely show up on a mammogram. This is not a palpable lesion, so you can't feel it. It can only really be detected by mammography. And here's another example. Again, lots of necrosis, ugly-looking tumor cells, all confined to a duct, so it's still all in situ. And then central calcification representing all the degenerative changes. But again, this tumor is at a much higher risk for invasion than others, so we always look around into the stroma to make sure there's no invasion. All right, what about lobular in situ? Again, now we're referring to the acinar units that make up the lobules that become neoplastic, not just the ducts. Now, I know it gets confusing here sometimes, because sometimes, especially on histology, the lobular proliferation sometimes expand into the ducts. And you get ducts that are benign but involved by lobular, okay? That gets really fun on histology, but we won't go there, okay? But anyways, just be aware there is this variety of tumor called lobular carcinoma in situ. It's like the atypical lobular hyperplasia we saw earlier, but more so, okay? So there's more proliferation of those lobules than we saw with the atypical one. Sometimes they lump them as lobular neoplasia. It's often an incidental finding, by the way. It may not even show any mammographic abnormalities. But the good thing about LCIS is it doesn't have to be treated as aggressively as DCIS, except if it invades. And invasion is another story. But LCIS is usually treated very conservatively. And again, histologically, this lesion shows a proliferation in one or more of the terminal ducts within the lobular units, where it's involving at least 50% of the acini in a given lobular unit. And they're composed of these small monomorphic type cells. Ductal cells tend to be larger than lobular cells in this setting, in these tumors. Keep that in mind. We'll look at that in cytology too. Lobular cells that are malignant are small. Ductal cells are a little bit bigger with a little bit more cytoplasm. Lobular cells are small, often with eccentric nuclei that kind of makes them look plasmacytoid. And we'll see that on cytology. So it's going to help you. And you will have to make the distinction between lobular and ductal carcinomas on cytology. All right, here's an example of LCIS, and you can see the whole lobular unit showing expansion of these alveoli, the acinar structures, by these bland monomorphic tumor cells. And they're even involving the terminal duct here, as I mentioned to you earlier, but it's just the tumor kind of expanding into the ductal unit. And that's very common. Here it is on higher power. Again, look at how monotonous. I mean, you look at this and say, how can this be tumor, right? But it's so they're very monotonous. But it's just the architecture is very abnormal. All right, what about invasive carcinoma? The first one we're going to look at is invasive ductal carcinoma. It is the most common type of invasive breast cancer, representing anywhere from 75 to 80% of the invasive breast cancers. The tumor often demonstrates a very dense fibrous stroma with a very hard or scurous consistency. And these lesions, because of that, when they get to a certain size, are usually palpable. But they're not going to be palpable unless they're at least a centimeter. Anything smaller than that is going to be a little bit harder to palpate. But they are very firm and have a very irregular border to them. So they're not like mobile and round and smooth like a fibroadenoma. They have very irregular margins to them because they're infiltrating into the adjacent stroma. Now, histologically, there are ductal cells that are consisting of either solid nests, tubules, or glands. If they're all tubules, we call it tubular carcinoma, or invasive ductal with tubular features, okay? So just keep that in mind. But oftentimes you'll see it invading as solid nests of cells. Cytologically, the tumor cells, again, we have low-grade and we have high-grade tumor cells. Low-grade tend to be very small cells, larger, and the high-grade tend to be larger, more anaplastic cells. Here's an example of invasive cancer on a mammogram, and you see this little density here, radiopaque density. This is actually a clip that was not put in the breast, but a little device put on the skin surface. The patient said, you know, I have a palpable mass here. So they put a marker on the skin there, and that kind of helps direct them to the area as well. And so this is actually the lesion right here. This is all normal breast parenchyma here, but you see this kind of density that kind of stands out with irregular borders. We call them stellate borders. So this was turned out to be an invasive cancer here. Here's one on a mastectomy resection. So this is one slice taken from the breast that's been inked on its deep margin with black ink. This is normal breast parenchyma over here. This is the tumor right here. Very hard, white, chalky, very firm. You can definitely, when you feel this, it's very firm in consistency. Yes? No. Well, the reason we ink is to look at the margins for the surgeons, because if you're, especially in these lumpectomy specimens they do now, they want to make sure they have a good rim of normal tissue surrounding the adjacent to the margin. They like to have a 2 millimeters. I know 2 millimeters doesn't seem like a lot, does it? But that's the rule. I mean, they like to have a 2 millimeter margin. And the only way we can measure tumor to margin is by having ink, so it shows up on the tissue section. Because we make those measurements from the glass slide, usually. And so the ink will then, what we'll do is when we take tissue sections for histology, we take a section from here to the margin so that we can see how close, and usually we'll take one from where the closest margin is, like, you know, over here, for instance, or over here. Now here's what it looks like on histology. Again, you actually do have a little focus of in situ carcinoma here as well, but out in the outside stroma surrounding that duct that's involved is invasive nests of malignant cells, some that are solid and some that show little acinar glandular formations. Remember, this is a type of adenocarcinoma, so it's going to look like invasive adenocarcinomas do in other locations. Here's one with more solid nest and a very dense desmoplastic stroma surrounding them that gives it its hard consistency on gross exam. Okay, and then invasive lobular, just a little bit about this because it actually has some unique features to be aware of. It's not as common as ductal. It tends to arise from the terminal duct lobular units. It can occur bilaterally, so if a patient gets it on one side, they're actually going to look at the other breast as well, and it can be multicentric in one breast. Unlike ductal carcinoma, which tends to have a very hard, scirrhous consistency, it tends to be more rubbery in consistency, which makes it even harder because it may not be palpable. Okay, and what these cells tend to do, instead of forming sheets and glandular structures invading in the stroma like ductal does, they tend to form strands of single cells infiltrating in the fibrostroma. It has been previously referred to as Indian filing, but that's not appropriate, right, anymore. It's Native American filing, right? Okay. But it just strands, single cells that are infiltrating the stroma. And the malignant cells are very uniform and small and monotonous, unlike some ductals. Here's an example of one. Now, first of all, this is a normal duct right here. Normal duct surrounded by tumor. And you can see how it forms this kind of targetoid arrangement. That's also a feature on histology for lobular. These are the malignant cells out here that are in small nests and single file. These are lymphocytes here. Here it is on higher power to show you the single file infiltrating pattern of these cells. Now look at how bland these cells are. But they definitely show nuclear atypia, nucleoli. You've got some vacuoles in some of the cells. That's not uncommon, sometimes filled with mucin. But again, sometimes they almost look like signet ring cells, and we'll see that on cyto too. All right, now these other variants of cancer are really, as I mentioned earlier, are just variants of ductal, but they have some unique invasive ductal carcinoma, but they have some unique presentations to be aware of. Medullary accounts for a very few, in fact, I don't believe medullary really exists anymore, to be honest. It's still in our grading systems, but we don't see this very often. It really has to meet some very strict criteria before it's called medullary. Most of them now we call invasive ductal with medullary features, okay? But what defines it as medullary is the fact that the tumor cells look high grade and form these syncytial sheets, oh, I can't say that, syncytial sheets of large epithelial cells that are very pleomorphic and anaplastic that are surrounded by abundant lymphocytes in the stroma. So the lymphocytic component is an important part of this tumor. And actually, that's a good thing. We have found, and you'll see this in the textbooks too, that the more the lymphocytes present, that actually is a good sign. It's a better prognostic sign for the patient. So despite how ugly these malignant cells appear in these patients, it's actually these patients actually do better. They have a better prognosis mostly because of this lymphoid component. And so that's what we look for. Here's an example of one. Again, you can say, well, where's the tumor? Well, it's all of this stuff in here forming these syncytial nests of high-grade malignant epithelial cells, surrounded by all these blue cells that represent lymphocytes. They're benign lymphocytes. They're not malignant. It's the epithelial component only that's malignant, sorry. Here it is on higher power. Again, look at all the lymphocytes here, and look at these epithelial cells that are often quite vesicular in appearance, okay? Open, chromatin. Now, what about tubular? Now, I told you that earlier. This is a type of ductal that just shows tiny tubules throughout a sclerotic stroma, a desmoplastic stroma, so it's invasive. But these tubules look very bland, okay? They're often composed of these very bland appearing malignant cells. They're still malignant because of their presentation. Now, what about colloid carcinoma? Again, just like in the colon, it's this very gelatinous tumor that's composed of abundant mucin. And the classic presentation is malignant ductal cells within these large pools of amorphous mucin. But sometimes you can have them mixed with other areas of typical ductal carcinoma and so forth. But here is an example of one. Again, here's this fibrous tissue. Here's tumor right here. But you see these malignant ductal elements right here and all over the place, just sitting in these large pools of acellular mucin. And here it is on cyto, kind of really highlights the mucin. Again, mucin is easier to recognize sometimes on DipQuick, and you see it stained as this purple material that's kind of has somewhat of a fibrillary appearance to it on the glass slide, but it stains this kind of metachromatic appearance. And then here it is on Pap stain. But the key is you notice the mucin. The key is finding the malignant cells that are kind of embedded within it or isolated separate from it, either way. And so don't get lost kind of focusing on the mucin, but oftentimes these tumors will only show a few isolated groups of malignant cells and then all this mucin on the slide. So don't forget to look for those cells. Definitely look at the epithelial component, and they definitely show malignant features. All right, what about Paget's disease? I told you this involves the nipple. And we've seen it in the vulva area as well. It's a similar type tumor, but the thing about Paget's involving the nipple, it generally means that there's another carcinoma deeper in the breast that's either DCIS or invasive ductal carcinoma. And what this means is that these ductal cells that are malignant are involving the epidermis. And it will give the nipple and the surrounding areola an eczematous appearance. So these patients will present with what looks like eczema or chronic irritation of the nipple. And they'll do a biopsy, and they'll see these large anaplastic, what we call Paget cells, often surrounded by a clear zone that actually are a variety of ductal cells that has spread to involve the overlying epidermis of the nipple and areola. And when we see that, then they go searching through the rest of the breast, you know, doing mammography, other studies, whatever, MRI, looking for the cancer, because there almost invariably is one. We confirm the diagnosis with special stains because these large cells are positive for mucin, EMA, CEA, and estrogen receptors, unlike other cells that can occur in the epidermis that are malignant, to include melanoma, which would be positive for what? Part 1, S100, HMB, right. So we usually, when we do these stains, we always do those to make sure it's not melanoma, because it can look kind of similar. Here we go. Here's an eczematous type of Paget's disease involving the nipple. Here's an ulcerating type. And you look at the epithelium and you see these large pale cells with these clear zones around them, kind of infiltrating throughout the epidermis. And here, and actually here's the adjacent duct cancer. It's a bad case. Oh my goodness. You have to think, how did she let that go so long, you know? But some people, you know, they just deny, don't want to go see the doctor, et cetera, et cetera. So I know, it's pretty sad. And here's the tumor, the Paget's tumor cells right here. What about inflammatory breast cancer? Now, despite its name, it's not actually that the breast is inflamed. There's no inflammatory cells. The reason it gets its name is because it looks inflamed. The breast actually looks reddened and warm. And the reason it does that is because all the superficial lymphatics that are in the dermis, just beneath the epidermis, become filled with tumor cells. And that's the bad thing. So basically it's, you know, there's a tumor mass somewhere, and then it has infiltrated into the dermal lymphatics. It's not a good thing. These patients usually present with very high stage tumor. They're already a T4, and their survival is very bad. But again, it's the involvement of those dermal lymphatics that give the breast this kind of inflamed appearance. Here's an example here. I mean, both breasts. It's horrible. And also the other description that you'll see is that the skin will have this orange peel, or what we call in French, peau d'orange appearance, which means orange peel-like appearance, peau d'orange, because the skin gets kind of mottled and thickened and so edematous that it gives it that kind of orange peel appearance. Now here is the histology. You just do a biopsy of one of those anywhere on the breast actually, and you've got the normal epidermis here, and then beneath that are the dermal lymphatics right here that are filled with tumor cells. And now this tumor is coming from another site in the breast, but the whole skin will be like this. So now you know why these patients don't do very well. Pretty extensive disease. All right, other rare malignant tumors that are seen, or unusual malignant tumors. We're not going to spend a whole lot of time with these, but just remember, all the different tissue types in the breast can develop a tumor. And again, probably, you know, tumors of stromal origin and lymphoid elements can occur, but they're rare. Mets can occur to the breast. The most common metastatic tumors involving the breast are melanoma, lung, ovary, sarcoma, GI, and urinary tract lesions. But melanoma in lung and ovary are probably the most common that occur. In men, actually, metastatic prostate cancer, not uncommon, can occur to the nipple. And so that's the most common cancer that will involve a men's breast tissue. But what about male breast lesions? Gynecomastia. This is a benign disorder, very common. It actually behaves like a fibroadenoma on histology and cytology. What it represents is enlargement of the breast tissue in the male. It can occur as a result of hormonal influences, mostly increased estrogen, which can occur in a number of conditions, to include patients with cirrhosis, those with Klinefelter syndrome, certain testicular tumors that can form excess estrogen, and certain drugs can cause this. It's not uncommon in young men post-puberty to get this, and a lot of it is because of all the hormonal influences. It causes a button-like subareolar enlargement, unilateral or bilateral, and you get hyperplasia of the ductal epithelial lining along with some dense fibrostroma surrounding it. And it looks just like a fibroadenoma does in a female. Remember, the men don't have lobular elements, so there are no acinar structures, no lobular units. It's all ductal and stromal tissue. And that's what we see right here. Here's normal fat, here's the fibrous tissue, and here's the ductal elements that often show hyperplasia to their lining. No atypia or malignancy here, but remember, men can get invasive ductal cancer. I'll show you in just a moment. This is not a risk factor for that. This is benign. It is not a pre-neoplastic condition or pre-malignant condition. Breast cancer can occur in men, very rare, at a ratio of 1 to 100. You get generally older men. And obviously, what is the most common type? Infiltrating ductal, with similar histologic and prognostic features as female type. Here's an example of a male breast cancer. I think this is one I saw like 5 or 6 years ago. That's the last time I saw one. With all the breast things we see, it's not very common. All right, so just a little bit about prognostic factors, because sometimes we get asked in cytopathology to help in the overall assessment of these patients, you know, doing axillary node FNA, for instance, because sometimes if they suspect, they've diagnosed a patient with breast cancer, and they have axillary node enlargement, they may ask us to do an FNA to confirm that there's tumor there. That would actually save them having to do the sentinel procedure, and then they just do, you know, if it's positive, they do they'll do the complete axillary node excision. Sometimes they need to get material for staging, for estrogen and progesterone receptors, sorry. Or sometimes they want to confirm that a patient has recurrence or a metastases with a prior diagnosis of breast cancer. So, you know, cytology plays a very important role here in a number of sites in diagnosing breast cancer. Breast cancer can often metastasize to the pleural fluid. You'll hear about that when you do the effusion cytology lectures. And we need to be able to recognize breast cancer in pleural fluids or in CSF. I mean, we saw one recently, a patient with metastatic ductal carcinoma to the CSF, and she was presenting with leptomeningeal spread, which is not good. It's a stage 4 tumor. So you have to be familiar with features of ductal and lobular carcinoma and to understand what are the important prognostic factors. Probably the most important is axillary lymph node status, the regional lymph nodes. So I've been talking about them all along. Tumor size, the T, is important. The overall stage, which is 1 through 4, just like other tumors. What's the tumor type? The histologic grade, low grade or high grade. Low grades have better prognosis. What's the receptor status? Because remember, when these patients are found to have ER and PR positive receptors in their tumor, they can be treated with anti-estrogen agents such as tamoxifen. But if they don't have those receptors, it's not worthwhile treating them with tamoxifen. The other thing we look at is HER2/neu status. You may have heard about that. And Herceptin. If they have tumor cells that are positive for HER2/neu, they can be treated with Herceptin. But not many tumors do have HER2/neu positive status. But every time we get a new breast cancer on histology, and sometimes we have to do on cyto as well, we always get ER, PR, and HER2/neu. It's a standard thing for every breast cancer patient. And of course, we can look at tumor proliferation, but we don't do a lot of testing on that. But it is something that may or may not help with the overall prognostic indications. But some people do it. It's not necessary, though. Oh, here's an example of a positive axillary node. Here's the residual lymph node out here, the lymphocytes here that are small. And then here's the met right here of the ductal cancer. So this is a macromet to the lymph node. You can get micromets that are defined as less than 2 millimeters in size. And you can even get isolated tumor clusters that are less than 0.2. Yeah, I know, we're like, we have to do a lot of measurements with breast cancer. Now, lobular can do strange things in lymph nodes sometimes. It can show up very focally and only in the capsule, beneath the capsule, in the sinuses. So here's normal lymph node over here, but if you look, here's the capsule of the lymph node, and right beneath the capsule in the subcapsular sinus here is a little metastatic focus of lobular carcinoma. This is a micromet here. Okay, it's definitely less than 2 millimeters and probably less than 0.2. All right, now again, I mentioned to you grade. We've got low grades and high grades, grades 1 through 3, well differentiated, moderately differentiated, poorly differentiated. Here's a histologic grade 1. It shows lots of good glandular formation and minimal cytologic atypia in those malignant cells. Here's a high grade 1. In contrast, there's no glandular formation. It's just a sheet, so there's no acinar structures. And those cells are very large neoplastic with frequent mitotic activity. So those are the things we look at for grading. Here's an example of estrogen receptor positivity. It's a nuclear stain. It's a nuclear immunostain. And we don't do ER, PR, and HER2 prognostic assessment at BAMC. It's actually recommended by CAP that you send them out to facilities that do them all the time to make, because there's some very strict guidelines with ER, PR, and HER2 testing. And it's been found to be better to send them to places that like do tons and tons of these and have a very good system in place and very good correlations. And so we send them all out to Quest. All right. Yes, Quest. Everything goes to Quest, right? But actually, every medical center in the military does that. Almost every single one. It's not unique to us. Oh, no. Hold on a second. I'm sorry. Excuse me for a second. I'll call you back. I'll still got a few more minutes. Sorry. All right. Breast cancer staging. Again, 4 stages. Stage 1 is defined by tumors that are less than 2 centimeters in diameter with no axillary node involvement and no distant mets. So stage 1 is the best. Stage 2 are tumors that are less than 5 centimeters, so they're a little bit larger and may have axillary node and or have axillary node involvement, but no distant mets. Stage 3 are those that have involvement of the skin, the pectoralis or chest wall, fixed nodal involvement, but still no distant mets. And then stage 4 is any breast cancer with distant mets, no matter its size or axillary node status. And distant mets includes things like, to the bone, to the lung, to the brain, to the pleural fluid, etc. Now, there's so many different procedures that we do in the breast for diagnosis. FNA still has a role, although I have to tell you the number of breast FNAs that are being done nowadays is much less than it was when I first started 20 years ago or more in pathology. I actually did a study on breast FNAs when I was at William Beaumont from 92 to 95. I know you all probably were kindergartners back then, but I used to do breast FNAs all the time. I mean, I actually remember in a period of 18 months, I did over 200 breast FNAs. Now, in an 18-month period of time, we maybe do 4 or 5. Why is that? Well, radiology has taken over our business. Okay. Darn those radiologists. No, actually, it works out better for a number of reasons. They have so many good image-guided devices that they can use now to get biopsies. They can do them by ultrasound. They can do them by mammographic localization, which is called a stereotactic core needle biopsy. They can use MRI to help localize lesions. So I wouldn't like that. Have you guys ever had an MRI? Any of you? It's kind of a freaky machine, isn't it? I had my first one 2 weeks ago for the ankle. I was like, oh my gosh, I never realized. Okay. I hope I don't have to have that again for a while. And then, but yeah, they can actually use MRI to do some localizations. They do that occasionally too. But yeah, it's better to be able to localize the lesion. And remember that now we're detecting these lesions earlier. They're not going to be palpable, right? So how are we going to detect them? By these image studies. So that's why it's so important to do mammography. And at the right ages, of course. Okay? You got to follow the guidelines. But again, you can do biopsies, lumpectomies. They can be needle localized if it's a non-palpable lesion. We can do smears on nipple discharge. Ductal lavage is done in very rare, few locations, but it is something that has been discussed and studied. We don't do it here. They don't do it at Wilford Hall. I don't dare say they do it in many places in the military, but just in some research institutes. But I'm not sure how useful it is, but it's still something that can be done. Again, FNAs, core biopsies, a little larger needle. Hopefully they give enough anesthesia locally. Surgical biopsy, open biopsy, needle localized biopsy. So what they do in needle localized biopsies is, after a patient has had a core biopsy done by mammography and they determine there's a lesion there that needs additional tissue, they always put a clip in after the needle biopsy, and then they can what they do is identify that area by another needle afterwards, and then the patient goes to the OR for the excision of that area. So it helps to localize the area. Ductal lavage example here where they're actually kind of aspirating material through suction method out of the nipple. You can imagine how uncomfortable that would be. Some people call it the breast pap smear. Actually, Hologic, excuse me, has a whole bunch of information on this because they were a big proponent of this, but it's really gone by the wayside a little. And they look for abnormal cells, atypical cells. There's different surgical treatments to be aware of. We've already talked about most of these: lumpectomy, axillary node dissection, sentinel lymph node biopsy, mastectomies, usually modified radicals. The radical mastectomy means that they also take the pectoralis muscle. They hardly ever do that. That's rare. I don't think they ever do that anymore. If they feel that a patient has involvement of the pectoralis muscle by cancer, which they'll know by preoperative imaging studies, they usually treat them with chemotherapy first and then do an excision because that shrinks the tumor. But they still have to do the excision. So that's called neoadjuvant chemotherapy. And of course, there's lots of new progress. Here's the next time in 2002. I'm waiting for, I guess this year we might see the new one, right? Okay, it's every 10 years about. Okay, so there's new smart drugs like Herceptin. They can actually map tumor cells genetically, so you can actually have specific molecular treatments. Oh, I mean, it's gotten so involved and complicated. Here's some examples. You can do radiofrequency ablation of tumors, look at tumors through endoscopy cameras through the nipple. I know you're thinking, oh my gosh, really? And then they can do targeted radiation of tumor cells. They can do molecular forecasting and do this microarray analysis to kind of tailor the right chemotherapy for that patient. Herceptin analysis to give, or HER2 analysis to determine if they can treat them with Herceptin, which is supposed to be good for patients with bad prognostic tumors. And of course, remember the screening guidelines. Yearly mammograms starting at age 40. Clinical breast exams about every 3 years for women in their 20s and 30s, and every year for women 40 and over. Breast self-exam is actually not recommended anymore, if you believe it or not, because they have found that breast exam is an option, but it's not required. Okay, they have found that it's not been very useful and helpful. The important thing is to get clinical breast exam where you actually go see a provider who does a breast exam on the patient. Women at increased risk may benefit from earlier screening or more additional tests and more frequent clinical breast exams. For instance, patients with BRCA1 or 2 mutation, and they find that out when they're young, they may start getting mammography or even MRIs when they're in their 20s or 30s, for more additional screening. But again, the standard is still, even though you may hear debate in the literature about this, is still to start mammograms at age 40. There's been a push to put that up to 50. I know you've probably seen that in the news, but it's still, and there's one organization that actually recommends 50. But the American Cancer Society still recommends that you start screening at age 40, and it's every year. And you'll get that when you're in the military, they will start your screening at age 40. Any questions? All right. Oh, I included a couple pictures from upstate New York here. This is the Thousand Islands, and this is Bolt Castle. It's beautiful there, isn't it? Very nice summer day. It's not like that right now. It's nice for like 2 or 3 months out of the year. It's just gorgeous there. I look forward. I'll be spending parts of July up there this year. I'm looking forward to it. All right, any questions? All right, then I'm going to save this recording, and I'll see you back here at about 5 after 12. How about that? Guys, the box, right?